The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. My name is Andrew Capehart with the APS Technical Assistance Resource Center. Welcome to the webinar. The title of today's webinar is ACL's National Voluntary Consensus Guidelines for State APS Systems, Updates and Revisions. And I'll introduce our speakers shortly. Next slide, please. A couple quick disclaimers before we get started. The Adult Protective Services Technical Assistance Resource Center, or APS TARC, is a project of the U.S. Administration for Community Living, Administration on Aging, Department of Health and Human Services, administered by WRMA Incorporated. Contractors' findings, conclusions, and points of view do not necessarily represent the official policy of the federal government. Next slide. And the guidelines were updated for the Office of Elder Justice and Adult Protective Services, Administration for Community Living, U.S. Department of Health and Human Services by New Additions Consulting Incorporated under contract. The contents of this presentation do not necessarily represent the policy of OEJ, APS, ACL, or HHS, and readers should not assume endorsement by the federal government. Next slide. A quick note about our APS TARC. We're here to help APS programs in any way that we can. Just reach out to us. Contact information will be displayed at the end of the webinar today. We work to enhance the effectiveness of APS programs by working with partners on use of data and analytics, applying research and evaluation to practice, and encouraging the use of innovative practices and strategies. Next slide. Please consider joining one of our peer-to-peer calls, as we call them. We have 3 calls per month, one for investigators, one for supervisors, and one for administrators. The schedule for these calls is on your screen now. Check out our website or email us if you'd like some additional information on these calls. We hope you can join us. Next slide. We also have a page on our site that's dedicated to COVID-19 and adult protective services. There's a link to this page in a red box at the top of our site, and then you also have it here. On this COVID-19 page, you'll find resource information and a summary of state program responses to the pandemic, and we encourage you to check that out. Next slide. A little bit of housekeeping before we get started. This session is being recorded and will be posted to the web at a later date. We'll notify all attendees via email when it's posted online. If you have questions of our presenters, simply type them in the questions box at any time during the presentation. We'll pause for questions at the end of the webinar, and we'll try to get to as many of your questions as we possibly can. All participants are muted for this webinar, and you must use your computer to access audio. If you have any problems with the audio throughout the webinar, we suggest exiting the webinar and then re-entering or starting it back up again. And then finally, today's slides are available to download now in the handouts section of your GoToWebinar control panel. So you can download them at any point that you like just by clicking on the title in the handouts section. Next slide. Now, a quick poll to get a feel for the professions of everyone in the audience. I'm going to launch this poll right now. People can vote by clicking directly on their screen and let us know which of the following categories do you identify the most with. Do you consider yourself an adult protective services professional, some sort of other social services professional, a medical professional, legal professional, or other, if none of these categories apply? So we'll leave this open for just a moment so that people can vote. And again, you can vote by clicking directly on your screen and selecting the one that you identify the closest with. Looks like we've got quite a few votes rolling in right now. I'm going to leave it open for probably another 10 seconds or so that people can submit their category they identify most with. So now I'm going to close that poll out and we'll share the results with everybody. It looks like 64% of you are adult protective services professionals, 15% are other social service professional, 2% of you are medical, 4% are legal professional, and then 15% consider themselves other from a category that doesn't correspond to the other ones. So thank you so much for participating in that poll. If you could go to the next slide, please. Now I'd like to introduce today's speakers. Stephanie Whittier Eliason is an Aging Services Program Specialist and Team Lead with the Office of Elder Justice and Adult Protective Services at the Administration for Community Living. I'm sure many of you know Stephanie. Mary Toomey is a consultant in the elder justice field and works with the firm New Additions Consulting for the Guidelines Project. She was also the architect of the original guidelines, and I'm sure many of you know her as well. And then finally, Anna Leopold is a senior project manager with New Editions Consulting and was intimately involved with this project as well. We have 3 fantastic speakers with us today. I will now turn things over to Mary Toomey.
Thank you so much, Andy. So I have to start by saying I was kind of disappointed to know that we weren't doing this by Zoom, because I actually got dressed and put on makeup for the first time in 4 months. But it's probably better that we're not doing Zoom. So I wanted to just thank all of you for joining us today to learn more about the APS guidelines, and specifically how they've been updated, the research that's informed them, the stakeholder comments that informed them. They are near and dear to my heart. What we want to talk about today is we want to explain the role that the guidelines play in ACL's vision for adult protective services. Why even have guidelines? And Stephanie is going to be talking about that. We want to then describe the process for how we went about updating the guidelines. As you all know, the guidelines were created in 2016, and this is the first update. So we were sort of walking down this path for the first time. So we want to talk about how we did it. And then most importantly, we want to describe the updates that were made to the guidelines. We want to focus our attention on some highlights. We can't go over every single thing that was updated, because there's just too many updates, but some of them are more significant than others. But before we go a little bit further, we're going to do another poll, because we're just curious. There are no right or wrong answers here. Please just be honest. How familiar are you with the ACL's National Voluntary Consensus Guidelines for state APS programs? I'm going to turn it back over to Andy.
Certainly. Thank you, Mary. I've launched that poll now. Just like the last one, you can vote by clicking directly on your screen. Before today's webinar, how familiar were you with the Voluntary Consensus Guidelines for state APS systems? Extremely familiar, very familiar, somewhat, slightly, or not at all familiar. So we'll keep this open for just a little bit and give folks maybe another 15 seconds or so to vote. Again, you can click directly on your screen. And I'm going to close that poll out here in about 5 more seconds. And I'll share the results with everybody. So I will share those now. It looks like 5% were extremely familiar, 17% were very familiar, 30% somewhat familiar, 18% slightly, and then 30% not at all familiar. So you got a mix, Mary.
Well, that's good, actually. So that, if you were all extremely familiar, you could be doing the webinar and we could take a break. So it's good to know that people are somewhat familiar, but we hope that by the end of this, you could say that you are very familiar with the guidelines. And, I want to turn it over to Stephanie now to talk a little bit about ACL's vision and where the guidelines fit in. So over to you, Stephanie.
Great, thank you, Mary. Hello, everyone, and thank you for joining the webinar today. We're very excited to roll out the guidelines this way to everyone. It's always more dynamic when we can do it and we can talk about it rather than just post a report. Interestingly, as I was preparing to talk about this slide, it occurred to me that although it looks like a linear progression, and we do have a linear progression of dates of when these different things became publicly available, they all actually sort of grew up, were birthed kind of at the same time. So in 2010, we have the Elder Justice Act that is passed, but it's not funded. And there's repeated calls for action and work and implementing the provisions of the Elder Justice Act. And we were fortunate in 2014 to have both an administrator and leadership within HHS that were very supportive of creating a home for APS. And along with that home, there were a few core activities that we launched or we dreamed about at the same time. So in 2014, our office was created, which is the first federal home of adult protective services. And at that time, we knew that there were some things that we wanted to do. First of all, we knew that we needed to support state adult protective service programs. You have a national organization, the National Adult Protective Services Association, that supports everybody from the state APS down to the local worker. But we saw a gap in what we could in what we could provide, which is the direct technical assistance and support to specifically the state APS directors who needed something a little different than what that had been available to them in the past. We also wanted to know the scope of the problem of elder abuse. How can we really design good prevention and improve what we do in addressing it if we don't really understand what's going on out there? So we envisioned, piloted, created the National Adult Maltreatment Reporting System, which is intended just to capture the phenomena of abuse, neglect, and exploitation as it's reported to Adult Protective Services. So we know we're only getting the tip of the iceberg, but it's a good place to start. And then at the same time, we knew that states were also asking for more direction from the federal government, and that birthed the project for the Voluntary Consensus Guidelines for state APS systems. So they were rolled out, those sequentially. 2014, we had our office. In 2015, we were able to put out a solicitation for the APS Technical Assistance Resource Center, the National Adult Maltreatment Reporting System. We piloted that in 15, but it didn't actually get rolling until a little later. And then the Voluntary Consensus Guidelines, that project was started way back in 2014, but to go through the process that you'll hear about, that did take until about 2016 for us to release those. So those are the cornerstones of what we are hoping to help build related to a national APS system. Data about the issue, support to states about some of the research and evidence supported ways to structure their systems, and then a technical assistance resource center to support the states in carrying out all of those activities. Next slide. Okay, so the goal of the guidelines, again, it's to provide a core set of expectations to promote consistency across the country in APS programs. As you all know, there's a dearth of research on what is the best staffing ratio, what are the best interventions, what is, for APS, how do we design our programs, what's the best way to do quality assurance. And so what we did is we saw an economy of scale, we had the resources, let's engage in a process where we can identify what are promising, emerging best practices. We want to make sure that people across the country are getting the same level of quality service and attention. And we also saw and understood the value that all of the research and practice was showing about interdisciplinary and multidisciplinary responses. And we also knew the challenges that APS programs were having in being able to get their programs, get approval for their programs to participate in a lot of these interdisciplinary responses. So putting out the guidelines was a way to support the APS programs in advocating for the change that they were looking for within their states. And ultimately, we hope that this will enhance your effectiveness, the efficiency of your program, and also be mindful and respectful of who our clients are in terms of different cultural backgrounds, economic backgrounds, different life experiences. So sort of trying to institutionalize that concept of being very person-centered and person in the environment perspective. And finally, though, I do want to say or reiterate, these are not regulations. These are not requirements. and there are no legal obligations in following these, and states do not receive any additional benefit from the federal government for trying to implement them or not. We served as a facilitator to the field to help gather the information and put something out for everyone's benefit. We are not serving as a regulatory body in this sense. Okay, next slide, please. And I do believe I'm turning it over at this point. Nope, this one's mine. Okay, I started to talk about some of this. We did serve as a facilitator of the development of the guidelines. And so what that meant is we coordinated massive stakeholder engagement and outreach with numerous different professions, not just adult protective services, but also in those different sectors that APS interacts with and works with, so that we could also understand some of the perspectives that they were bringing to the table. This is always meant to be for APS, but at the same time, we can point others to it to say, look, this is what APS aspires to. These were developed for the field by the field. They are consensus driven and field developed. So if you want to know about what APS needs, then you can start to look at the guidelines for an initial understanding of that. We didn't take an arbitrary approach. We did follow the National Institute of Standards and Technology and Office of Management and Budget process for creating such field developed consensus driven guidelines. There's very specific recommendations for that. And we also sought to avoid any duplication or complexity in the guidelines. And so we were mindful of other recommendations that were out in the field, and we address or include them as appropriate for any of the different domains. And again, that is also consistent with some federal guidelines, federal regulations, as you see on the screen. So that's the overall summary of our approach. And with the next slide, I'm going to turn it over to Anna.
Right. Thank you, Stephanie. Good afternoon, everyone. So based on the responses on the poll, it looks like some of you are familiar with the guidelines and others maybe not so much. So before we go into talking about the guidelines content, I want to briefly go over what the guidelines cover and how they are structured, as this will help you as we go into the presentation so you can follow along regarding the content. So the guidelines are organized by domains or topics. There are 7 domains, and that has not changed from the first version of the guidelines to the updated version, although we have revised the title for 3 of the domains slightly. So here on the slides, you see the domains the guidelines cover. They basically cover all APS practices, from program administration to receiving reports, conducting the investigation, all the way to program performance and quality assurance. So as I mentioned, we have slightly revised 3 of those titles. So for instance, domain 5 used to be called service planning and intervention. We now, in the updated version, call it service planning and service implementation. The 6th domain used to be just training. It's now worker and supervisor training. And domain 7 used to be evaluation / program performance, and we now call it program performance and quality assurance. So these are the 7 main topics, or domains as they're called, for the guidelines. And then for each domain, there are several elements or subtopics. So for instance, program administration has 14 elements or subtopics, so that's the broadest domain. A little more about the structure of the guidelines. For each element or subtopic, there is a background section that talks a little bit about the research and provides a little bit of an overview of the topic. And then the second part is the actual guidance statements for the guidelines, going into what the guidance is. Okay, next slide. Okay. We started the process for updating the guidelines in late 2018, and we applied a 3-phased approach to updating the guidelines, and I'll talk about those phases in a little bit more detail on the next slides. But basically, the approach we used was similar to that used for the original development of the guidelines. So it included multiple steps, with each step building on the work from the previous step. And these steps included first a literature search and a literature review, then drafting updates based on the findings from the literature, then engaging stakeholders to obtain feedback for those proposed updates, and then engaging a technical expert panel to finalize those revisions. Next slide. Okay, so first I'll talk a little bit more about the literature. Okay, as you may know, the first guidelines were really based on research. So what do we know in terms of studies, what's effective for APS? So the research that the first guidelines were based on was research from 2004 to 2014. So for the updates, we replicated that literature search, but we searched for new research that was published between 2014 and 2018. The positive is that the APS research field has really grown quite a bit in the past year, so we're able to find quite a few articles, research articles on APS that were relevant for the guidelines. So we had 24 articles that we were able to use. We read through all the articles, looked at the findings, and tried to map them to the different domains of the guidelines. And we're able to find research that was relevant to all but one of the domains. So we had no new research related to domain 3, which is receiving reports of maltreatment. There were also some studies that we used for multiple of the guideline domains. So what we did then is we looked at the findings of the research and drafted updates. So at some instances, we added text to the background of the guidance, and in other instances, we added text to the background and the actual guidance statement. However, we did not change, or we did not remove any of the original guidance, so there wasn't any research that contradicted what was already in the guidance. Next slide. So this slide provides a very broad overview of the topics that the new research focused on. We're not going to go into too much detail today. If you're interested and want to know more about the research, there is on the ACL website with the guidelines and standalone appendix. And that appendix has a summary, and it summarizes all the research that we looked at. But to give you some indication of the topics that were addressed in the research we looked at, there was research focused on services and service delivery. There was research on specific APS procedures, such as the use of decision supports and goal attainment. And there also was research focused on a range of outcomes, including client outcomes, outcomes related to the investigation, as well as outcomes related to training and APS workers. So that included outcomes related to exposure to hazards, job satisfaction, and also secondary trauma. Okay, next slide. Okay, so now I'll turn it over back to Mary, who will talk a little bit about the research and what the impact of the research was on the updated guidelines.
Thank you, Anna. So I wanted to talk about one of the roles of the guidelines is to inform the field about research that has the potential, the findings of which have the potential to enhance APS policies or practice. And so we wanted to highlight some of those examples for you. As Anna mentioned, sometimes the research informed the background and of the domains, and sometimes it actually informed the guidance. But whether it informed the guidance, the background, or the guidance, the research is really important. When we did the first guidelines, there were 8 studies that we were able to cite in the original guidelines. In this new guidelines, as Anna mentioned just a second ago, there were 24 research articles that we felt really enhanced, provided information that we thought was really important to APS workers and supervisors and administrators. So I'm going to just go over a few of the highlights from the research and tell you a little bit. You'll see later when we talk about what actually changed in the guidelines, you'll see this Geschieri study mentioned again, but this is the first study that I'm aware of that really looked at the hazards that APS workers are exposed to. So you see that this study, which I don't remember how many people they talked to, but that in this study that it was an average of 3.42 of different hazardous exposures per month. And what I thought was interesting about this study, if you take a closer look at it, is that the authors say that based on previous studies from child welfare, that they suggest that if stressors identified in this study, the study about APS, were addressed effectively, that worker turnover in APS would decrease. So how are we taking care of our workers? How are we addressing the issues related to their exposure to hazards? And especially now, we are so much more aware of that than when we were writing these. So this is just something I wanted to make sure that people knew about this study, and you'll see later where it actually enhanced the background in 1K worker safety. Another study that we wanted to highlight is a study that I think sort of nudges adult protective services in the direction of looking at the feasibility of using tools or systems to standardize collection of information, never taking away the clinical judgment and expertise of the worker, but what is the impact when you provide a tool that helps the investigator organize work in a different way? And that, according to 2 studies that came out a couple years ago, that we saw increased substantiation rates compared with normal APS protocols when the worker was given a standardized tool to use as part of the investigation. So you'll see where this changed and enhanced the background in 4A, determining if maltreatment has occurred. So again, we're not going over all the research that was interesting, but these are just sort of highlights that we wanted to address your attention to. The section related to 5A had a lot of research, and what's interesting to me about this is this is the bulk of what you all do in terms of providing services to people on a voluntary basis. This is the actual investigation. And so if we start at the bottom, the 3rd bullet, you see that what people have found in the study is that if you're working with a client who has mental health needs, partnering with mental health providers, in this study that was done in New York, they actually worked very closely, had a memorandum of understanding with their mental health provider. So it wasn't that APS was encouraging the client to go get mental health treatment, and this was for the client, not for perpetrators or others. It wasn't that you were making a referral to those people. They actually were like down the hall. And so that the worker was going with the person to the mental health provider. It was all done seamlessly, not even a handoff. It was just done as part of the voluntary service implementation. And people with mental health needs got much higher results. And in fact, I think there was, well, I'm not going to say it because I'm not positive. I was going to say something about whether the clients returned to APS at higher rates or not. And the second bullet, also, this is a topic that is sort of a double-edged sword, but there's starting to be more research about, especially for clients who are entrenched and clients who are reluctant to receive services, that longer-term relationship-based interventions are more effective with those clients. And I think that's kind of a no-brainer, of course, but that's not always what APS can do. But this is the study that showed that the longer, with these entrenched clients who are reluctant to receive services, the longer that relationship could be held open. And there was also talk of the use of motivational interviewing. Those clients did not return to APS with the same rates as normal practice for APS. So again, the guidelines recognize that sometimes the guidelines are aspirational. You may not have the luxury of being able to keep cases open because of your regulations, because of funding, but when you can, how can you recognize that the study by Merriam et al. Could enhance APS practice? Similarly, the first bullet point, and I don't know why I started with the bottom one, but anyway, similarly, we see that when studies are showing that when clients, this is about social isolation and clients having really bad after effects of maltreatment, the more that APS intervention can build social support and participation in supportive community social outlets, the less negative outcomes there will be for the client, and the lower the risk of future maltreatment. So the example I always give here is again, this is pre-COVID, but if you were an APS worker and you realized the client needed help was food insecure, and you were suggesting that they could be a candidate for Meals on Wheels, or they could be a candidate to go to a congregate meal site, you might choose to have the client go to a congregate meal site, all other things being equal in terms of mobility and the client's ability to get to the congregate meal site, because that would increase social connection in a way that potentially having a home delivered meal might not. So this is just encouraging APS to think about isolation as a real predictor of negative outcomes, and to do something in the plan to recognize that in your plan. There were several studies that are about training and how important training is in terms of staff knowledge, confidence, in terms of higher rates of substantiation, higher rates of investigation. So I remember a time, I live in California, but I remember a time when we were trying to encourage our assembly to give more money for APS training, and we could not cite a study that said training translated into better outcomes for the worker, for the client. We are starting to see that content. So I encourage everybody to learn more about that. If nothing else, it might be helpful to you in making your case before your funder. And finally, the last one that I wanted to highlight in terms of how this research actually did change the guidance. So we are looking at things like, how do we measure when APS when APS is saying what a difference it made in the lives of clients, how do we measure that? And this study by Burns et al. Is talking about one of the ways to measure that is to set up goal attainment scaling. So this allows for different goals to be set up for each client, but it also allows a scientific way for you to create this individualized set of outcome indicators and study them. So what did the client say she wanted, and how, obviously, this is with the client's goals have to be feasible. So it's not just saying the client says, I want a new house and a new car, and APS can or cannot deliver that. It's a very scientific way to have the client's voice come into the APS planning process and service delivery process. And also in terms of evaluating program performance, it gives you the ability to say, what difference do we make in the lives of clients? So that was just a little bit about how the research, this review of the 24 articles and the findings, a few highlights about how that work informed the guidance. And I'm going to turn it over to Anna to talk about the second phase of the updating process.
Thank you, Mary. So as Mary mentioned, so that was kind of the first phase, looking at the research and developing draft updates to the guidelines based on the research. So from there, we engaged the field to obtain feedback for those proposed updates. So the stakeholders in the field, really anybody who was interested or was invited to leave comments on ACL's request for information page, or to participate in one of 5 webinars. Next slide. So we held 5 webinars and had about 190 individuals participate, representing 39 states and DC. And individuals represented multiple different fields, but the majority really came from APS, as was to be expected. So we collected all the comments and then did some analysis of all the comments we received. As part of our analysis, we found that 278 of those comments contained relevant feedback that we could use to further refine the updates that we had made. So the comments were really related to the proposed updates, but also to the other content that we hadn't changed. but we consider really all of these comments. So of those 278, 216 were related specifically to the content of the guidelines, to the actual language in the guidelines. And then the other 62 were related to other topics. So having to do with the structure of the guidelines, disseminating the guidelines, how we present them, or research gaps as well. Next slide. So this slide, this graphic here shows you a little bit of the breakdown of where the comments fell that we received. So as I mentioned, the guidelines consist of 7 domains or topics, and most of the comments we received really were related to the first program domain, guideline domain, which is program administration, which is not surprising because it's also the broadest topic. So about 28% of the comments were related to that domain, followed by domain 5, which is service planning and intervention, and then domain 6, training. So even though we didn't make any updates or didn't have any research related to domain 3, receiving reports of maltreatment, we still received a few comments for that one as well. So if you want to know more about the entire process, everything that went into the analysis, if you want to see some of the comments and also how we coded them, you can again go to the ACL website. There is a separate standalone appendix that summarizes everything we did and all the results. So there's full transparency. Next slide. Right, turn it back over to Mary.
Yeah, thank you, Anna. So the final phase of the updating process, and not dissimilar to the way we created the guidelines, is we kind of convened a brain trust. This is a technical expert panel, 9 different people that were APS professionals as well as researchers in adult protective services. They had a mighty task. They reviewed all the new research and its applicability to the guidelines. They reviewed all the stakeholder comments and determined whether they were applicable to the guidelines. And then they also sort of, because they were bringing real world experience and real wisdom, they also, in some cases, identified topics that had not been addressed by the research or the stakeholder comments. And so their comments also impacted the final guidelines, the updates that we made. And so I wanted to just turn our attention now to the guidelines and the updates that were made. And we can't cover all of the changes that were made. I guess this is the time to say some of them were very small. They might just have been the change of a word. In others, the changes were more significant. We are also creating a document that will be sort of like a brief that will highlight all the changes that were made, that will be available at some time. That at ACL's request, we are creating that. How did the guidelines change? But this is your sort of quick and dirty introduction to that. As we've all said, there are 3 sources of the updates: the research, stakeholder comments, and we are very grateful for all the stakeholder comments that came in. They were very wise, and they were really on point in terms of ways that the guidelines could be improved. And then also the deliberations of the technical expert panel. There were a couple global changes. So we created a glossary for the first time so that when we're using the word, investigation, everybody can turn to the glossary and say, okay, that's what they mean. Or we're using the word adult maltreatment. What are we referring to there? Again, you can see we have namers data that we didn't have from the first guidelines. So we were able to integrate some namers data. We also had language in the first guidelines that sort of showed what was child welfare doing. This was not, it was not intended to encourage adult protective services to be like child welfare, but it was sort of contrasting the 2 different systems. Like in child welfare, they have funding for training, and this is what kinds of topics are, child welfare workers have to be trained on. This is what we have on the adult protective side. So we added language to make it clear that we were not saying APS should be like CPS, more just that CPS or child welfare has these resources that Adult Protective Services doesn't have. So those are some of the global changes that we made. So I'm highlighting just a few of the changes. As I said, they're here, they're all here, and there will also be a brief that you could access later on the ACL website. But we wanted to just show you a few of the things that we thought were important. So the very first one is just a change of one word. As I said, sometimes the one word being changed is a little thing, sometimes it's a big thing. In this case, I think it's kind of a big thing. We're recommending that the Code of Ethics and ethics policies be reviewed annually by Adult Protective Services programs. And so it's not something that you just do with your staff when they're onboarded. It's something that you would make a commitment to do every year. I could imagine people having a ceremony that this is our ethics training, and we're going to all sign the Code of Ethics again and recommit ourselves to person-centered, least restrictive alternative practices, etc. Turning to 1B, which is the subject, the element is called protecting program integrity. So we changed, added some language that said APS programs and policies, APS program policies and standards should be transparent and available to the public. This is as a result of stakeholder comment, so that comment was included. We also, for the first time, added a section on providing information on the rights of perpetrators. So, for example, their right to be informed of and to appeal a finding by an APS program, their right to know about registry, if you have a registry in your state. That's the kind of thing that was not captured in the first guideline. So I think that's both of those in terms of protecting program integrity are valuable enhancements. Under mandatory reporters, we added language that said that it's recommended that mandatory reporters be immune from civil as well as criminal liability. Civil was left out of the first guidelines, so I think that's an important addition. Under staffing resources, we augmented that content to discuss the importance of the ratio of supervisors to direct APS personnel, to highlight the role of the supervisor and the risks to clients if there is no cap on the number of supervisors, number of workers that supervisors have to supervise. So that, I think, enhances this section, and I hope will give people some content to be able to share with others about why it is important that supervisors that there be a cap on the number of people that supervisors are asked to provide oversight to. As we go through, as Anna mentioned, section 1 is a very long section, the administration section. Now we're looking at the timeline section. We're moving to client closing the case. We mentioned the Burns study that looked at goal attainment scaling and added to the reasons that could be for closing a case, that are listed for closing a case, that client goals have been achieved to the extent feasible. Again, putting in feasible, recognizing that sometimes clients' goals may not be exactly feasible, but we think that's a research-based addition and enhancement to the closing the case. In terms of the APS client assessment, we wanted to make it clear that APS workers do not carry out clinical, or unless specifically qualified or authorized by state law, APS worker does not carry out clinical health or capacity assessments, but screens for indications of impairment, screens for decisional ability, and as needed, refers the client on to qualified professionals for a thorough evaluation. So that was not clear in the first guidelines, so that language makes that much clearer, the role of APS in terms of looking at decision-making ability and capacity. Some of these other changes, I'm just going to go to 4C, even though I didn't highlight something there, is things we received some feedback that APS, when possible, should notify the ombudsman when APS is going to investigate allegations of mistreatment in residential facilities. So just encouraging that collaboration and collegiality with our partners there. If we look at 5A, voluntary service implementation, this is where above we talked about several research articles that have come out that informed the background section of this. This is a section where it actually also informed the guidance. So language was added to encourage programs to provide longer-term interventions for entrenched clients. And I'll say again, something we talked a lot about when we brought out the first guidelines was that just like NAMERS asks you to submit data points, and many states don't have data on the data points that NAMERS is asking you to submit. So, and to that degree, NAMERS is setting a bar and encouraging states to start collecting data so that we can have data on, for example, other things that we think are important to understand adult maltreatment and to understand how APS helps people. Similarly, the guidelines also sometimes set a bar, and I think this is one of those places where the guidelines are aspirational, but again, the research is supporting this kind of longer-term intervention. So there's a tension between when the guidelines are encouraging programs to do something, but also recognizing that it may not always be possible. But I like that part of the guidelines that's saying, here, look, research is showing that this is something to aspire toward. And when funding is there, you know now that this is something that might work for a subset of your clients. We talked about this programs when you have a choice to encourage in your planning with clients, programs that enhance social support and break down isolation. More and more research showing that that is important, and added language about working in partnership with mental health practitioners. I don't know, I get all excited when research can be seen in real life, when you can see how research could help you do your job better or do your job differently. And with obviously the whole impact of the guidelines is to increase services to clients and to improve client outcomes. So the thing I wanted to highlight on this slide, as we're coming sort of to the end of all the updates, there were two under 6B, caseworker initial and ongoing training. That section on training is pretty robust, and there we've added two new topics as a result of stakeholder engagement: motivational interviewing and cognitive deficits, which includes dementia. There's a lot more about supervisor training and ongoing training for supervisors too, thanks to the good work of the people at San Diego State University and their APS leadership development project. So I also commend them to you. And finally, I think as Anna mentioned, the APS program performance, that domain was called something else. It was, for the first time, it was divided into two sections, and that text, that content was significantly boosted. One suggestion is that that was not in the first guidelines, is that APS keep data long enough to ensure their availability for things like quality assurance, for identifying trends, for tracking client recidivism. So if you're in a state where you purge your records every 6 months, this would be a recommendation that, is that long enough? That would beg the question, is that long enough to be able to use the data for your program performance needs and program evaluation needs? And then going back to the Burns study, that study informed the trend, I think, more and more to looking at how is APS helping the client? What kind of client outcomes are we studying? So in addition to the metrics that you might normally collect on how many cases were open, how many cases were closed, within what time frame, all of those quantitative elements which are important, and need to be studied, but what about the information on how did APS make a difference in the lives of clients? How do we do that? Goal attainment scaling is suggested as one particular one way that you could do that, but there are states that okay, maybe one state that I'm aware of that has actually experimented with sending clients some sort of follow-up to ask about their satisfaction. How do we work together to figure out how can we do more to get information about how the client's life changed as a result of APS's working with that client. So just going to pause there. There's a lot of information. Again, we're going to have a brief that will, in addition to these slides, that will outline all of that. I guess what I think is important is that this is a body of information that is going to continue to evolve and grow. So we will hopefully be updating the guidelines on a regular basis. And in addition to their role as providing us with research findings, they become something, as Stephanie mentioned at the beginning, that we all programs start to have in common. So, I feel like ACL is looking at that a little bit. They just finished a pilot program where 4 states were given technical assistance to see how their program policies and procedures align with the guidelines. And the states identified several spots where several issues where they wanted to have their current policy manual change to reflect, to be more in alignment with the guidelines. I feel like that kind of work is really important, and hats off to ACL for funding that. And that's the kind of thing I think that programs can do on their own as well. So it's always nicer to have a little technical assistance to help you do that. And then the last thing I'll say is that the guidelines also, because we were looking at research, and because research specifically in the area of APS is still, even though it's growing, it's still small, that we also created the first ever APS research agenda that hopefully will be the subject of a separate webinar, and we can talk about how that was done and what we hope to see done with this APS research agenda. We still have too many questions that we don't know the answers to, but I'm happy to see that there is so much more in the guidelines, this updated version, than there was in the initial guidelines, and I think that's something that we should all take as encouraging news. So let me give it over back to Anna.
Okay, thank you, Mary. So one of the things we also heard after the first guidance were we said they were a little bit challenging to use. It was just a very comprehensive document, which is great to have all the information, but to really disentangle the background from the actual content. So part of the updates we made is we revised we put a new design together for the guidelines. So there's one actual guidelines document that really talks about, that has a background and then the actual guidance statement. And then all the other content we put in standalone appendices that you can also download. So there's an appendix that is the glossaries, and there's another appendix that summarizes all the research, and then there's an appendix that summarizes the actual updates and how that was done and what the results were from that process. So this is what you see on the slide here is kind of a snapshot of what the guidelines look like. So you have here an element, the example here is 1K, you have the background section, and then kind of trying to distinguish the guidance statements. We have some color background to really emphasize what the guidance statements is in the guidelines. So hopefully it's easier for users to use the content and be able to process it. Next slide. Also, there's quite a bit of research that we referenced in the presentation today. So we just want to make sure you have those full references. So I'm not going to read these, but on this slide and the next slide, you get to have a full list of the references. and you can look them up in your own time if you're interested.
All right, thank you so much, Mary and Anna. I think if you're ready for questions, we'll go through a few of the questions that we received. And it looks like we're getting close to time to wrap up. So if people can stay on the line with us just a little bit over, we will get to some of these questions. So first of all, is just a clarification about an acronym. Can you please clarify what LTCO is an acronym for, what it stands for? Again, that's LTCO.
Oh, sure. Long-term care ombudsman. I hope that the first time we used it, but yeah, sorry about that.
Yeah, no problem. Another question, and some of these are about some of the research that you accumulated in the process of updating the guidelines. Have you completed or have you seen any research on the effectiveness of having APS housed under area agencies on aging versus other social service agencies? And I'll repeat that. Have you seen any research on the effectiveness of having APS housed under area agencies on aging versus other social service agencies?
I'll just jump in, but Anna or Stephanie or Andy or Leslie, anybody else, I have not. There are several questions around sort of where APS is housed, how APS is organized, whether it's a county-based system, state-based system, that I would love to know the answers to, but I'm not aware of anything. Anybody else on the line?
This is Oh, go ahead, Anna.
Yeah, I was just going to say, not in the research we looked at from 2014 to 2018, but there may be something that's been published since then.
And again, this is Stephanie, and that is actually something that ACL is looking into through our contract with the WRMA under the APS TARC. We have a evaluation survey that we were getting ready to field this year along on sort of organizationally about APS so that we could start looking to see if there were any differences under a number of different administrative kind of characteristics. And we also, as many of you may know, are engaged in doing a outcomes evaluation, which is also on hold until next year. So we're hoping that we'd be able to get information out and within a year of fielding those surveys. And that again is that hopefully if we can do it, if nothing in the environment changes, that would be next spring. So hopefully by, spring 22, we'd be able to start rolling out information, if not sooner.
Great. Thank you, Stephanie. And I know, Mary, you had asked, I'm not aware of any research either. This is Andy Capehart. Yeah, that's a good question, but I'm not aware of any research on that. Another question about the research that you accumulated. Any thoughts on whether states should continue to maintain registries? And I assume by that it means abuse registries. Again, any thoughts on whether states should continue to maintain abuse registries?
There were no, there were no studies related to registries that informed the guidelines. And in fact, the guidelines are silent on the subject of registries.
Great, thank you. And I think about half the states have some form of registry. So I know they're not in every state that are out there. So another question, how many revisions have there been to the guidelines thus far?
One.
All right.
And Stephanie, I just want to add to that, Andy, there's only been one. And our schedule is to try to do it. It was to try to do it every 2 years when Anna and Mary and the team engaged the stakeholders about the frequency of updating the guidelines. I'm going to embarrass myself. It did not change. Is that correct, Anna and Mary?
Correct. It was kind of mixed, kind of a split between 2 and 3 years. Mm-hmm.
Great, thank you.
Mhm.
And then a final question, and I think we'll wrap things up. Where can we access, or is it possible to access any of the studies referenced in this presentation or referenced in the guidelines? Again, is there any place that the attendees can access the studies referenced in the presentation or the guidelines?
Yep, so if you go to the ACL website where the guidelines are posted, there is one appendix, which is, I think, Appendix 2, and that summarizes has an abstract for all the research and then the full reference. So you can just copy that reference and put it in your search browser and try to find it. For some of these, you may need access to journal articles, to journal subscriptions, but some of these may be free as well. But again, there is a brief summary on all of these articles in that appendix.
Wonderful. Thank you so much, Anna.
Yeah,
go ahead.
Andy, I was going to say, I think this is that maybe the person asking the question is like, you know, I know I can't because I don't get these periodicals. I don't get the Journal of Interpersonal Violence, or I don't get the Gerontologist. And I mean, this is a larger question. I believe that NAPSA now includes in its membership a discounted rate to the Journal of Elder Abuse and Neglect. And several of these studies were published in the Journal of Elder Abuse and Neglect. But it is a hard thing, I think, in any profession, that the amount of money one would have to spend as a individual to have access to all of those articles is actually kind of high. And I just think it does beg the question, how does one, you know, maintain, if you have an interest in research and how it informs practice, how do we might want to sort of figure out how do we help people get access to this information without breaking copyright law, because these,
right,
you know, these are studies that are published and the authors have the right to keep them. So it's something I think that is worth a longer conversation. But as Anna mentioned, the studies themselves are cited in the appendix, and you know, sometimes authors are happy to, you can contact authors. Sometimes authors are happy to send the materials, but at least you'd be able to get an abstract in the appendix that Anna mentioned, if not the full article.
Great. Thank you so much, Mary. And I think we're just a few minutes over, so I think we'll wrap things up at that point. If you don't mind going to the final slide real quick. And just a reminder, you can download the slides on the handout section of your GoToWebinar control panel if you want to download them now, but we will post them online in addition to the recording of this webinar today, and everyone who registered will receive a notice that the webinar has been posted and the slides have been posted so that you can review it. You've got our contact information for the APS TARC up there right now, our website and our email address. Reach out to us anytime if there's anything that we can do to help you. You can also find us on LinkedIn, on Facebook, and on Twitter as well. And there will be links in the PDF download copy of the slides. Thank you so much to all of our speakers today, Stephanie Whittier-Eliason, Mary Toomey, and Anna Leopold. Thank you so much for all the great work that you've done on these guidelines and for sharing it with us today. I know that everybody on the line is really grateful to receive the information. And thanks to all of our attendees today for joining us. We hope that you'll join us for the next APS TARC webinar. Have a great afternoon, folks.
Thank you. Bye-bye.